Hi there. December 2017 saw the introduction of the renewed cervical screening program in Australia and the release of the associated updated cervical screening guidelines. This has presented some management challenge to clinicians as we all try to adjust to the updated guidelines and the change in management. What we're going to do today is aim to discuss some of the more commonly encountered clinical challenges to try and assist us in making sure that we're providing the right test at the right time to our patients with appropriate follow-up in place. All of the cases discussed today and the information are taken directly from the updated guidelines, which can be found at the website shown on the screen now. So for case 5 today, I'm going to cover women following up after hysterectomy. Again, this is a bit of a minefield because depending on the indication for the hysterectomy or the woman's past screening history, we're going to need to determine what follow-up this woman may need. So case 5 is a 52-year-old woman who has attended for her yearly vault smear, which she's been coming in for every year since her hysterectomy 5 years ago. Now, in determining follow-up for this woman, we really need to look at the reason for her hysterectomy. Is there a past history of a confirmed high-grade lesion? Did she have her hysterectomy as treatment for a confirmed high-grade lesion? If the hysterectomy was done purely for benign reasons, such as fibroids or heavy bleeding, and the woman has had a completely normal screening history, then she probably doesn't need to have ongoing vault smears. There's a separate section of the guidelines that specifically looks at management of women following hysterectomy, and you'll see there on the screen now that there is a flowchart that looks at management of these women. It's important to recognise that no further surveillance is needed if a woman has been treated for a histologically confirmed high-grade lesion and has completed a test of cure. Or if there has been no evidence of cervical pathology on her hysterectomy specimen. So it's really important in managing these women that we need to find out the type of hysterectomy that a woman has had. If a woman has had a subtotal hysterectomy, that means that she may still actually have a cervix, so she does in fact need to continue 5-yearly cervical screening. It's important to track down the exact histopathology of any past abnormalities or of her hysterectomy specimen, because sometimes what was actually found on histology may differ to what the woman may think she had go on in her history. So that's really important to try and track down the information as best as possible to determine the woman's future screening needs. If there was any record of adenocarcinoma in situ on the histopathology, the woman will need to have indefinite annual co-testing. The National Register is currently being phased in, and one of the current operations of the register is that you are able, for women with past abnormalities under the old program, to contact the National Register to find out details that may have been recorded previously at register level of previous abnormalities. So that is a function of the register that's currently up and running that may assist clinicians in helping to determine history for these women.